goes.
Yeah, hopefully. And then I think I connected you with Dr. Mahmood too, right?
Yeah, I'm not really sure what is I did and then I didn't and then I didn't hear back, so I wasn't really sure what we'd had a few like I anyway, I'm not really sure. If I left
Yeah.
I gave
Because you CC'd me
dates.
on an email after you emailed me that, and he wrote back that same day and was like, "Yeah, Dr. Tanno, I emailed you back a couple times. Are you not getting my emails? Did you not get that one?"
It seemed like he hadn't gotten some of mine. It was weird. So
Yeah, yeah,
I told him to check his spam folder because I wasn't really sure what was going on. But yeah, and I had sent him recently a few dates, so and I hadn't heard back. So I don't know if he, not wanting to like commit on a date. I'm not sure, but anyway, if he's interested, tell him to check his spam folder because I guess everything might be going there. I'm not sure.
maybe. I think he's definitely interested because he's our newest partner and he's trying to get his like name out there, and he's got a
Yeah,
lot of time on his hands. So I'll follow up with him. Or maybe, do you
yeah,
mind if I give him your cell phone so you guys could text or something?
sure. Yeah, yeah, yeah. I know, but it is a it's a I don't know. I think it's a wild time. Also, I think I get 500 emails a day these days, whereas normally our office gets very, we're usually a minimalist kind of email office of
Yes.
between 5 and 10 total in the whole day, and now it's like 5 and 10 before 9 a.m.
The virtual world that we live in now.
Are you guys all virtual at your office, or what are you guys
No,
doing?
so the office is fully open. We're seeing all our chemo patients. We're fully operational. I'm just kind of temporarily working from home because of the kids and all that stuff, but I'm going back in 2 weeks. But everybody else, we are doing telemedicine for patients to keep them safe, and we're trying to minimize the exposure to the chemo patients. So we're trying to bring less people into the office. But yeah, no, we're all like in the office full time, except for me temporarily right now. But
Yeah, and then do you have a lab in your office, or do you send out?
we have a full lab, but that's also a problem too, even just getting people's labs drawn. Then there's a big lineup for the lab, and we have all the chemo patients that are such high risk. So we're trying to actually right now not use our lab unless it's for our chemo patients. So it's this whole big thing. It's a whole
Yeah,
different
yeah.
shift in what we're doing. Yeah.
I know. I feel like we're having similar conversations on our end for sure with our lab is now, it used to be appointments and drop in. Now it's just appointment only so that they can control the number of people per
Yeah.
hour and they can space people out, in advance, and they can make sure they have all the orders in advance so nobody's just standing there waiting if there are no orders. Um,
Yeah. We're doing all the same. Yeah. It's crazy what we have to, prepare for that we didn't never think of before.
yeah. Do you guys go into the hospital at all, or what do you guys do when your patients are admitted?
We do. We have privileges at Shady Grove and Suburban and Holy Cross Silver Spring and Holy Cross Germantown. So
Okay.
like Dr. Mahmood does all the Holy Cross, and then the rest of our kind of seven of us do Suburban and Shady Grove.
Oh, okay. Oh, okay. Yeah. I guess people always ask us that question of like, if I get admitted, are you going to see me in the hospital? And I always say, we don't do inpatient medicine. I mean, I think they used to. I don't know when they stopped doing it. Um, but I think most hospital systems are going to like a hospitalist
Yeah.
and and then your outpatient primary care doctor.
Yeah.
Um,
Yeah, no, totally. I think, and right now, because of COVID, I mean, we're like trying to minimize how much we're going in because we, again, don't want to bring it back out to our chemo patients. So, like, even when we are in the hospital rounding that week, we're not going on any of the COVID floors. And then, like, if there's any even person of interest, we're not going in that room. And so, we're doing kind of like virtual hospital consults for anybody that has COVID. So, like, if any of our chemo patients get admitted, of course, we still need to be involved, but we just can't risk transmitting it to other people. So
yeah. All right. Well, it looks like we have some people here. So let me just
yeah, I keep seeing the numbers. It was like two, then like 20.
I know, and then suddenly like 10 will join in 30 seconds. It's sort of it's an unpredictable curve for sure. But so for those of you guys who are on our call so far, I am Dr. Tanno. Today we have Dr. Shannon O'Connor, who's a hematologist oncologist. I'll come back to some introductions on her, but let me just make some announcements for the week. So as you know, today's talk is about genetics and cancer. And Friday, we have Dr. Moskowitz, who's one of our clinical psychologists, and Dr. Holmes, who's one of our new to the practice internists, is going to talk. They're going to talk about implicit bias in healthcare. We're trying to do a little series on some of the recent news events on race in America, but we're trying to come from a medical objective angle of it. So Friday's talk is implicit bias, and out with the email there was a link that was sent that had it's a test you can take for yourself of how much implicit bias you had. And so there's different categories. You can do one on race, you can do it on gender, you can do it on weight, you can do it on a lot of things. It's all the things that we probably judge people by that we would like to think that we don't, but we do. And so this test is given by Harvard, and they have a score essentially on how biased you are. So it might open your eyes in some ways. So it might be helpful to do that link before the talk on Friday if you get a chance. Just might come with a little bit more insight. So that's Friday. And then we're still hammering out some lectures for next week, but it looks like Dr. Kelly Cowan, who I know many of you guys see, again with Dr. Holmes, are going to do a talk on medical marijuana. It looks like Dr. Cowan has her medical marijuana license and has been doing some small scale medical marijuana visits. So they're going to talk a little bit about that next Wednesday, the 24th. And more people might sign up for next week, but we're still hammering that out. But it looks like we have a decent number of people, so I don't want to keep you guys who are on time here waiting too long. Today we have a wonderful speaker, Dr. Shannon O'Connor. She is a hematologist oncologist. So for those of you who are scratching your head wondering what that is, so all of us go to medical school for 4 years, then we go to residency for about 3 years in internal medicine. Then you can go on and do a fellowship in any, in many things, rheumatology, rheumatology, endocrinology, pulmonology, all these things. But Dr. O'Connor did 3 years of extra 3 years of hematology and oncology. So sometimes I send patients to a hematologist, and when they see the name oncologist, they get very anxious, and I tell them the training is all lumped into the same fellowship, and so it just depends on where they focus. But Dr. O'Connor is from this area. She's from Washington, D.C. I'm sure she could tell us more on exactly where she grew up, because I'm sure all of us know this area quite well. She did her undergrad at George Washington University, her master's at Georgetown. She went to St. George's University for her medical school, and then returned back to DC to do her residency and her fellowship at Georgetown University and Washington Hospital Center. As I said, she's board certified in internal medicine, and then she has additional certifications in hematology and medical oncology. And she also did completed a City of Hope clinical cancer genetics program. So her focus is in some genetics, and she's currently a partner at Maryland Oncology Hematology. I'm sure can tell you more about that specific office and where they're located. They have an office in Rockville and Germantown, and she focuses in women's health, including breast cancer, gynecologic cancers, and hereditary cancer genetics. And today she's here to talk about some of the genetics around different cancers. And then, just because we always like to know a little bit about some interested people, she's married, she has 2 daughters, she likes to hike, bike, and travel, and she does partner acrobatics and trapeze arts with her family. So for those of you who like to submit questions to the chat and the questions for our speakers, please ask her about that, because I'm dying to know about it too. And so with no further ado, I will let Dr. O'Connor take over, and then she'll be open for questions throughout and at the end. So please submit your questions so we can have an interesting discussion. All right, thank you.
Okay, thank you for the introduction. I was going to say I can start briefly by explaining the trapeze art acrobatics part if people are interested in that while we're waiting for people to log in. But There's a trapeze school in downtown DC near the Navy Yard, near Nats Park. And my husband actually started doing trapeze about 6 years ago and was very, very advanced and actually was going to be one of the instructors. He's also a physician. So on the side, doing some trapeze. And we all got involved with it too. I used to also be a gymnast, so we were all doing flying trapeze. My little daughter is actually one of the most advanced kids at the trapeze school. And my older daughter does some silks and some gymnastics and things there, and then trampoline. And then I just recently started doing partner acrobatics, which is a partner stunting thing where I have a partner that like lifts me in the air and throws me around and I do flips and he holds me up, and so it's like circus arts. So yeah, the whole family, we do circus arts, so we're kind of the circus family plus doctors at the same time. So it's an interesting hobby, but obviously everything's on hold right now because of COVID and the trapeze school is closed. But if any of you are interested, the trapeze school, once it reopens, they do beginner classes. First time, you have to have no experience at all, and it's very, very fun, and a little bit scary because you're about 2 stories up flying on the trapeze, but it's really fun. So anyway, so I will switch gears and see if I can share my screen, hopefully, get this working. Here we go. Let me know if that's working. Okay, perfect. And then I'm going to do that. So let me see if I can minimize.
Yeah, looks good. So we see that, and then we have a little thumbnail of your video of your face.
Perfect. Okay, well, I will get started. So I wanted to pick a topic that kind of piqued people's interest. So I thought, are you at an increased risk of cancer? I feel like everybody really wants to know that. And so I do specialize in hereditary cancer genetics, and I'm going to do a very brief introduction to hereditary cancer genetics. This is very basic and short because I could lecture on this for 5 hours, and I know you guys don't have time for that. So it's going to be just hitting the surface. So if you have questions, please submit those to me. Let's see if this is going to advance. Let's did this earlier. It's not advanced. Okay, there we go. So genetics of cancer. I want to really point out that actually most cancers are not genetically linked. So only about 10% of all cancers across the board have a strong hereditary component, meaning an identifiable gene, something that you or the patient is born with that caused that cancer. So most people think most cancers are hereditary, but it's actually just the opposite. Only 10% of all comers with cancer will have an identifiable gene. So that's an important thing to know. So 75% are sporadic. They just occur. We don't know why. Maybe there's environmental things that occur, diet or whatever else, and chemical exposures or just random bad luck. 15 to 20% are what we call familial. Now, this is a complicated category, which is there's a family that has a bunch of cancer. I mean, lots of cancer on one side, all different types of cancer, and you can't really pinpoint one syndrome that might fit with that family, but there's definitely a lot of cancer going on in the family. We may do genetic testing on all of those family members, but we can't necessarily identify a gene. And so we know, hey, something's going on there because there's so many people with cancer, but we just can't find the gene that's causing it. Now, some explanation of that may be there's a gene, but we haven't discovered it yet. It just scientifically hasn't been discovered. That's possible. Another thing is, again, lifestyle choices, obesity, where people live in family groups, if they're near radiation exposure or some sort of a cancer cluster area. So there's a lot of other things that play a role in the familial cancer. So that's kind of an area that's being studied now. And there's actually a little bit of genetic information, which is called single nucleotide polymorphisms, which are little patterns of genes. So if we do the genetic testing, the actual gene is normal, but there's patterns of genes that line up next to each other, and the certain way they line up may actually increase risk of cancer. So that's a whole 3-hour topic that I don't have time to talk about today. So that's a very interesting area of genetics right now. The other important thing about the genetics of cancer is that there's multiple genes that have been implicated with cancer. So most people know about BRCA, or the BRCA gene, which causes breast cancer and ovarian cancer. But we know of about 20 different breast cancer genes right now. There's 15 to 20 different colon cancer genes. We know about 84 different hereditary cancer genes at this time, whereas only a few years ago we knew about less than 20. So it's really, the research in genetics is really advancing, and we're learning about more and more genes every day. So it's really important if you or anyone in your family has been tested for a specific gene, especially BRCA1 or 2, that may not actually be adequate testing in this day and age now that we have more research and more genes that have been discovered. So we'll talk about that a little bit later. Now, I only have one kind of basic slide about how cancer occurs. And so the top half of the panel is non-hereditary cancer. So you can see, I hope you can see my cursor, these blue cells over here are just normal, normal parents, normal offspring. All their genes are perfectly normal. The way cancer develops is there's a mutation in the DNA in a cell, and that's what that little blip right there is. The first mutation, though, occurs by chance. We don't know why it happens. I mean, DNA mutations actually happen all the time. That's actually a normal part of physiology, but your body can overcome that DNA damage, repair it, and go on its way and, be a normal cell. No cancer develops here. But if you get a second mutation in that similar gene or the same gene on the other chromosome here, meaning this cell has 2 hits, now 2 of its repair mechanisms are down. This is when cancer develops because the body cannot correct these 2 hits right here. So this is a regular person that has no genetic mutations. Cancer occurs really sporadically. The first mutation occurs but sporadically, the second mutation occurs sporadically, and then cancer develops. So that's the majority of cancers. The bottom panel here is hereditary cancer. So one parent has a faulty gene that they pass on, the other parent did not. This child or offspring gets a faulty gene, so they're already born with this first mutation. They already have that one hit that they're born with. The second mutation occurs again by chance, but that again, statistically is more likely to happen at a younger age because DNA mutations happen all the time. And so that's why hereditary cancers are usually presenting themselves at a younger age, in the 30s, in the 40s, in the 50s even, whereas an average person wouldn't get cancer until their late 50s, 60s, 70s, 80s. Now, that being said, even if you have a family member that had cancer at an older age, older than 50, it could still be genetic, but you really have to look at the pattern in the family. But this kind of explains why hereditary cancers usually occur at a younger age. And again, here, it's rare that hereditary cancers develop just because these genes are not that common in the general population. Hereditary cancer syndromes, there's a million of them. I don't have time to talk about them today. A couple of the highlighted ones are BRCA1 and 2. There's a gene called CHEK2, PALB2, ATM. These are kind of the most common mutations that we see in the community if we're going to detect anything. And with colon cancer, there's a common syndrome called Lynch syndrome that is made up of multiple different genes. And these are some other colon cancer genes. But again, I don't have time to talk about all of this. But the point is, if you've ever had genetic testing or are interested in genetic testing, it should never just be one gene, 1 or 2 genes. There's always a whole panel of genes that you need to consider with each type of cancer. I couldn't get out of just doing a brief introduction to BRCA1 and 2 because I think it's important and most people have heard of these genes. These are the most common breast cancer genes. If we do detect a gene, it's most likely going to be BRCA1 and 2 or 2. It's up to an 80% chance of breast cancer in the patient's lifetime if they carry one of these mutations, and up to a 40% ovarian cancer risk. But the important thing that most people don't realize is that these genes also cause prostate cancer, pancreatic cancer, and melanoma. So some people come to me for genetic counseling and they say, oh, but I have no, breast cancer in the family, but I have 5 people with pancreatic cancer and 5 people with prostate cancer and 3 people with melanoma and 1 person with ovarian cancer. That's actually a pretty classic picture of a BRCA1 and 2. So it's really important to know everybody in the family's history, what type of cancer they had, not just breast cancer, which is what most people are looking for in the family. The other important thing about BRCA1 and 2 is 1 in 40 Ashkenazi Jewish patients will just have this mutation. It's just a very common mutation in the Ashkenazi Jewish population. So even without a family history, it's actually a very common gene that the Ashkenazi population will have. So if you or anyone in the family or anybody that's Ashkenazi, that's actually one of the main indications to consider genetic counseling and genetic testing. And it's because most Ashkenazi patients will have at least one family member that has cancer somewhere in their lineage, and that is an indication for genetic testing. So the guidelines for the Ashkenazi population are pretty liberal. So almost all Ashkenazi patients can qualify for genetic testing. So that's important. I wanted you guys to know that. This is a study that was done a couple of years ago, and it was 1,700 breast cancer patients, and they all had genetic testing. Now, this slide does not mean that 68% of that 1,700 had a BRCA mutation. It means out of the 10% of the 1,700, so about 178 people had a mutation. Of the patients that had a mutation that was detected, a genetic mutation, 68% of those people had the BRCA1 and 2 mutations. Because like I said, those are the most common breast cancer genes that we're going to find. But the important part of the slide is that 32% of people that had a mutation that would predispose them to breast cancer had another mutation besides BRCA1 and 2. So again, this is really, really why it's important to always be considered for what's called a panel of genes, not ever just BRCA1, BRCA2, or just BRCA1 and 2 together, because you would miss about 32%. A third of the patients would be missed if they're going to carry a mutation. A third of those patients are going to be missed if not a broad enough panel is done. So this is very clear evidence in the genetics world that everybody really qualifies. Who's going to do genetic testing really needs a broad panel of genes. Now, I don't want to overwhelm anybody with this slide, but this is a just important thing to consider. Most genes, these are all the breast cancer genes, the most common, not all. Most breast cancer genes and other types of genes that cause cancer are going to cause more than one type of cancer. And so BRCA1 and 2, you can see here, like I mentioned, cause ovarian, pancreatic, melanoma. These other ones, CHEK2 causes colon cancer and breast cancer. Some of these bad guys down here cause almost every single type of cancer that there is. So again, this is the value of doing a full panel of genes, because you don't want to miss that 32% of people that might have these other genes, because then that could, change their screening for colon cancer, change their screening for other types of cancer. So if you just said, hey, you're BRCA1 and 2 negative, you're safe, you're good, that's actually not an accurate statement, because they might have one of these other genes that could put them not only at risk for breast cancer, but other types of cancer. And we can make a difference in preventing or detecting these cancers early. This is one slide on Lynch syndrome. I don't have a lot of time to talk about it today. I wish I did, because it's a very interesting syndrome, but it's a colon cancer syndrome that's made up of multiple different genes. And as you can see here, it doesn't just cause colon cancer. It's well known for colon cancer, but it causes colon cancer, stomach cancer, pancreatic cancer, urinary tract, including bladder and kidney. For men, prostate. For women, ovarian and uterine cancer. So this, again, this syndrome, a lot of people think about it for colon cancer, but it actually alters, if a patient is found to have one of these mutations, it actually alters their screening and prevention for all these different types of cancer. And so again, if you're looking in your family and you're saying, oh, well, I don't have anybody in my family with colon cancer, but hey, I've got a couple stomach cancers and bladder cancer and ovarian cancer, uterine cancer, that could still be this Lynch syndrome. So it's really important to meet with a genetic specialist that would know that and would, test you for multiple different types of genes that could affect your outcome. Now I'm going to switch gears a little bit and kind of focus on, what is genetic counseling, who needs genetic counseling, what is the process of getting genetic testing if you do qualify. So these guidelines are actually new, and this is not all of them because I didn't have a slide big enough to fit all of them, but these are just the big takeaways that I would like you to think about. So who needs to consider genetic counseling? The new recommendation as of 2020 is any person with breast cancer. So even if they're 99 years old with breast cancer, if you have only one person in the family with breast cancer, that person with breast cancer needs to be tested. It doesn't matter how old they were when they had the breast cancer. They had it 30 years ago. Now they're fine. They still need to consider genetic testing, because again, we really know a lot of genes in breast cancer, and we think that that could be important for those other types of cancer that I just mentioned. So it may change your screening and your management of those other cancers. Any person with ovarian cancer. Now, ovarian cancer is one of the cancers that actually has a higher rate of a genetic mutation. That's why any patient with ovarian cancer does qualify for genetic testing and counseling. So it's a higher rate than just the 10% of all comers. That's actually closer to 30 or 40% of patients with ovarian cancer are going to have a genetic mutation that we can detect. And so that is why we recommend any person with any history of ovarian cancer and any family history of ovarian cancer, same thing, because it is a higher rate of mutation in those patients. Anyone with even a family history of ovarian cancer needs to consider genetic testing. Most patients with metastatic cancer, and the reason for this is because once the cancer has spread around, it's twofold. If the cancer is spreading around, it's a more aggressive cancer. Genetically linked cancers tend to be more aggressive. So that's a little bit of a red flag, like, well, now this cancer is spreading around and behaving badly. It may be linked to something genetic. Again, the vast majority of metastatic cancer patients do not have a gene, but they need to at least talk to their doctor about getting genetic testing done. The other reason it's important for metastatic cancer patients is that it does alter the treatment options. So if a patient with metastatic cancer has a genetic mutation, usually we can have a targeted therapy that would target that genetic mutation that could actually help them, do better and live a little bit longer. Now, so for most of you, I hope, don't have cancer and you're just kind of an average person that is, healthy and doing well, but you need to really think about what's in your family. So if you have any family history of cancer under the age of 50, that's kind of the magic number. Any cancer, breast, colon, uterine, really any cancer under the age of 50, you need to talk to your doctor about whether or not you need to have genetic counseling done, because that's that hereditary model that I showed you, that cancers are going to be more likely to occur under the age of 50 if they're hereditary or genetically linked. Again, any family history of ovarian cancer, even if it's in your grandmother or your great aunt or something like that, that family really needs to be closely looked at. Anybody in your family that has metastatic cancer, again, for what we just talked about, because those are a little bit more aggressive and could be genetically linked. And then anyone that has at least 3 family members on the same side, meaning on your mom's side, there's 3 family members, or on your dad's side, there's 3 family members, not one from mom, one from dad, here and there. 3 family members on the same side of the family. 3 is really kind of the magic number. Of 3 cancers on the same side of the family is a bit of a red flag. So you should talk to your doctor about genetic counseling at that point. And then, as I said before, really any Ashkenazi Jewish person who has anyone in the family that's ever had cancer, which is almost all of us have cancer in our family somewhere. So I would say most Ashkenazi patients that I see are going to qualify for genetic testing. So really all the Ashkenazi patients should consider genetic counseling. So what is genetic counseling? It is you would meet with myself. I'm a physician. I also have a nurse practitioner that did the same training course that I did. So both of us see genetic patients. We do a full visit called genetic counseling, where we take a full pedigree, which is a family tree. We would ask you, how many children do you have? How many brothers and sisters do you have? How many aunts and uncles do you have? Are your parents still living? Are your grandparents still living? How many siblings do your grandparents have? So we do this whole family tree and we build it all up and build it out. And we look and see if there's a pattern of cancer on either side of your family. And then we decide, but based on that family tree, are you at increased risk of carrying a gene, or do you qualify for genetic testing? During that visit, again, we do these personal risk of cancer based on your family history. We do a full informed consent process about what does that mean to get genetic testing. We do a personalized risk-based screening model. I'll talk about this a little bit more, but basically, even if you get genetic testing and you have a negative test, you actually still may be at increased risk of cancer because of that familial cancer I described before. So there's these statistical models on the computer that we can put your information into, and it can actually calculate your risk of cancer. That's mainly for breast cancer. But we can actually say, based on your family history, even if you don't have a genetic mutation, you still may be at an increased risk and you still may need extra screening. We also go through the privacy laws. There's a law called GINA, which is kind of like HIPAA, but for genetic information, where it keeps your genetic information private. You can't be discriminated against based on your genetic information, although the caveat to that is long-term care insurance and life insurance. So that's a big deal for my younger patients when I see them. I really don't recommend that they get genetic testing until they have their life insurance kind of all straightened out, because life insurance policies can actually reject you or raise your premiums based on your genetic material, and that's state to state. So it's not all states, but some states do that. And again, I think it's important to see a genetics professional because most primary cares and general doctors do know about BRCA1 and 2, and they could order that test, but they don't necessarily keep up with all these other genes that we learn about every day. And so again, it's always appropriate to do a panel of tests instead of just the single gene or one or two genes. And again, we would also look at your family tree and decide who needs to be tested in the family. So maybe your mom had breast cancer and ovarian cancer. We would say, you know what, maybe your mom needs the testing if she's still alive and doing okay. Maybe she's the better person to test because we might have a higher yield of getting a gene if in the person that actually had the cancer. So we can do that whole assessment at the visit. Now, what is genetic testing and what does it entail? Well, you have that appointment with one of us. We're doing 100% virtual right now because of COVID. And I actually think I'm going to continue the virtual telemedicine genetic counseling because it's been working really well. And it's a type of good patient that really doesn't need a physical exam. And it's more just a conversation back and forth. So I think I'm going to keep that up, ongoing as long as I'm allowed to do that. So virtual right now and probably always in the future. The testing is actually a blood sample. Usually when we're in the office, we have our own lab. We just do the blood sample and send it off to the genetics company. But right now we're sending saliva kits to your home. So if you do qualify for testing, we FedEx you a saliva kit. You spit in a little tube, put it back in the FedEx and send it back to the genetics company and they run the test. It takes about 4 weeks to get the results back. The big question I always get from patients when I see them is this going to be covered by insurance? And if not, how much is it going to cost? Well, genetic testing used to cost about $6,000. So if the insurance didn't cover it, it was a pretty big deal to, pay $6,000 for a blood test or a saliva kit. But now, because of technology, they can do so many tests on the same machine, and the technology has advanced so much. The out-of-pocket cost in the company that I use is only $250. So even if your insurance says, I'm not going to cover it, or we don't think you qualify, or whatever else, you would only have to pay $250 out of pocket for the test. And we do all the insurance authorization and everything, after we meet with you and order the test, we do all the insurance authorization. And if by some chance the insurance doesn't cover it, then you pay $250 to the genetics company, not to us. And that's what pays for the test. So it's really affordable these days, which is the bonus. And then after if you do qualify for genetic testing and you do saliva kit, we would meet back with you about 4 weeks later at what's called the results disclosure visit. And we meet back no matter what. Even if your genetic testing is negative, we still meet back with you because, again, we would put you in through that risk model that's on the computer to see if you'd still be at increased risk. Or based on your family history, you may still qualify for some extra screening, even if we can't pinpoint a gene. A classic example is, we have 12 people in the family that had colon cancer and they all got tested and they were genetically negative. We can't find a gene, and you got tested and you're negative. We can't find a gene. I would still say you need a more frequent colonoscopy. You need a colonoscopy at a younger age. You need to be more proactive because there's clearly something there going on in your family. So we would give you a personalized plan, even if your genetic testing is negative. Now, what happens if you're positive? Again, we would give you a personalized plan based on that gene. And each gene has a different level of risk for all those different types of cancer I showed you before. It may be an 80% chance of breast cancer, but only a 20% chance of colon cancer. And what does that mean? And how often do you need colonoscopies? Same thing for either breast cancer risk or pancreatic cancer screening or whatever else. I would say, okay, now you need a breast MRI and a mammogram. Here's the schedule. You need an MRI of your pancreas. Here's the schedule. Or you need surgery to remove your ovaries to prevent ovarian cancer. So I would, again, myself and my nurse practitioner would give you a personalized plan based on the guidelines for that particular gene, and try to detect the cancers early and or prevent the cancers with surgery. And then the other important thing about a positive result is anybody who has a positive result with the company that I use, they do free family testing. They used to do free family testing for 90 days after you get your report, but now because of COVID, it's 180 days. So if you have a genetic mutation, all of your family members are eligible for free testing through that same company. They still would be recommended to see a genetic specialist like myself first, and that's a separate visit, and that's not free. That goes through the insurance, but the actual genetic testing is free for any family member of a positive mutation carrier. We talked already about the negative results. If you're negative, I would put you through that risk model and determine if you need any extra screening, so I won't spend time on that. And then really honestly, my last slide is what other risk factors increase your risk of cancer? So please don't anybody smoke. I mean, smoking is very bad. It causes almost every single cancer under the book and a million other medical problems. So smoking is bad. Chemical exposures, environmental exposures, radiation exposure, not just from CAT scans, but just heavy radiation, toxic environmental chemicals. Other things that you can't really control: early menstruation, late menopause, having no children, a longer period of having estrogen in the body as a woman, that actually increases risk of breast cancer. History of a breast biopsy, even if it was benign, that actually could put you at an increased risk in these statistical models, because it's a red flag that there was something abnormal going on in the breast. And even though it wasn't cancer, it's a red flag for maybe something abnormal could happen in the future, and maybe you could actually get a breast cancer in the future. So even history of breast biopsy can put you at increased risk of breast cancer. And then obesity, which is a very large problem right now in the United States. Obesity causes many, many, many health problems, including increased risk of cancer. So you can mitigate that risk by losing weight, don't smoke, stay away from toxic chemicals, things like that. Okay, this is my last slide. Takeaway points. I know I went through a lot of information and I'm trying to be kind of fast so you guys have times for questions, but most cancers, again, are not genetic. So just remember, don't panic. Even if you have cancer in the family, most cancers are not genetic. Most are sporadic. So unless you really have that, a lot of people in the family with a cancer or any of those kind of key cancers I told you about, ovarian cancer or cancer under the age of 50, probably most of the people in your family did not have a gene. But I still think it's important. Some people, I'm hoping you take away from this, you know what, let me go look at my family, see if there's been cancer in anybody, ask my sisters, my brothers, my aunts, my uncles, my grandparents if they've ever had cancer. Some people don't talk about it. Some people would not have disclosed that information to you. So just doing a little bit of digging to say, hey, is there any cancer in the family? If so, how old was that person when they were diagnosed? What type of cancer was it? Because that's important, because we need to see if it follows a particular pattern. And again, there's many, many cancer genes, not just BRCA1 and 2. We always recommend the panel. And so I bring this up just to remind any of you that may have already had genetic testing. If you just had BRCA1 and 2, that test needs to be updated. You need a panel of tests. If you did qualify for BRCA1 and 2 testing, you most likely are going to qualify for a panel. And the same thing with if you had BRCA1 or 2 testing longer than 8 years ago, so really the early 2010 or prior, you may need to update testing, because we didn't even know about the whole BRCA1 and 2 genes at that point. So even if you were tested in like 2010 for BRCA1 and 2, you might actually need an update of the BRCA gene, because we didn't even understand the whole gene at that point. So that testing is outdated. So I usually recommend, if you've had testing longer than 8 years ago, that you may need an update and you may need to see a genetic specialist. And lastly, I think it's important, I'm glad you guys listened to my lecture, but it's always important to talk to your doctor. Don't just assume you need genetic testing or get, panic and feel like you're going to get cancer. Just talk to your doctor. They can do a quick family history with you and decide whether you need to see a specialist like myself. So on that note, that's a picture of my cancer center in Rockville. We have the cancer center in Rockville, the Aquilino Cancer Center. We have a Germantown office. I'm there 2 days a week. I'm in Rockville 2 days a week. And we also have a Bethesda office where my nurse practitioner is as well. And then we are doing everything virtual right now. So the office location doesn't matter as much. But if you do feel like you qualify, or your doctor agrees that you qualify for genetic testing, then here's our information. And I'd be happy to, answer any other questions at this time.
Yeah, that was wonderful. I think, even for me as a primary care doctor, I have a lot of patients who will say, well, can't you just draw my BRCA1 and 2 genes? And I'm like, no, because I'm not equipped to do the counseling that comes with it. But then even just knowing there's so many other genes to draw gives me extra ammunition to say, no, you need to talk to somebody who really is well versed in this. So for those of you guys listening, please submit your questions. We have a few coming in so far.
And I'm trying to get the.
Yeah, no, it's okay. I'll read them out.
Okay.
It's hard when you're like on that screen. So the first one is, this is interesting. If you are
Dr. Tanno.
Oh, yeah.
Tanno, sorry for interrupting. We just lost power at the office. Is this still going? You still have all the attendees and everything?
Yep, everything here looks the same.
Okay, well then carry on. Sorry.
Yeah, and it's recording. Okay. So
okay.
First question. This is interesting. If you are adopted and you have no information on your biological family, is there any point or reason to get genetic counseling?
So that's a good question. I think that's actually more reason to get genetic counseling because we don't know what your family history is. And so there could be a ton of cancer in your family. There could not be. But I usually recommend genetic counseling, at least for almost all my patients that are adopted, because yeah, you can't get that family history. So I believe knowing more is better. So I think a general panel of just the most common cancer genes would be appropriate, even if you're adopted. Yeah.
And what's the insurance coverage on that? Is there any coverage?
Yeah, so worst case scenario, if they kind of balk at that because you're adopted, you just pay the $250 out of pocket. And you do the regular visit to the insurance, which they cover, and then the test is only $250.
Okay. And then there's a question here that I think maybe got partially submitted. Somebody just said, I had 3 lumpectomies and radiation. So I'm not sure what the question is. So please resubmit that. And then we have a lot of questions here. So I think a lot of these questions were submitted before your talk, so maybe you answered them, but so questions about expensive, where can you have the testing? You can meet with one of these genetic counselors and do it. There's a question here about sun exposure. Does sun exposure lead to melanoma? Maybe talk about some of maybe the interaction between genetics and environmental factors for some cancers.
So there's definitely still sun exposure can cause melanoma and other skin cancers. But if a person has a genetic mutation, that could be amplified. So it's that 2-hit hypothesis I showed you. So if you already have a mutation in a gene, let's say a BRCA gene, and then you're out in the sun a ton, which already is going to cause some DNA damage and cause increased risk of cancer, and you already have an inherent gene, that's going to really increase the risk. So yeah, for all of our mutation carriers, we say avoid, the sun and avoid, high risk behaviors like that. But if you're just kind of a regular person walking down the street and you don't know if you have a gene, then yeah, sun exposure can cause melanoma. But melanoma also can be caused by non-sun exposure. So it's a little bit complicated. But yeah, if you know you have a gene that increases risk, you should avoid things like the sun and other things that could provoke it.
Okay. And then this is maybe a little bit more of a specific question. So sometimes I tell patients that you might just need to make an appointment, but a patient said, I had a breast biopsy in 2008, breast cancer in 2015, 3 lumpectomies, radiation. Do I definitely need genetic testing at this time?
Yeah, so the new guideline is any patient with breast cancer at any age, at any point in your life, needs to be considered. And the reason is because, again, we know a lot more about the breast cancer genes. Some of them are kind of more common in the community. And also it could change management of other types of cancer you could be at risk for. Because so if you already got a breast cancer, you could have a gene. Again, it's about a 10% chance we're going to find a gene. So 90% chance that you're not going to find a gene, but all breast cancer patients at any age, any time in their life that had a breast cancer need genetic testing.
Here's another more specific question. My mother, age 62, and brother died of lung cancer. On my mother's side, 9 cousins, aunts, uncles died of lung cancer. Wow, it sounds like minors or something. I was followed with CAT scans, but nobody suggested genetic testing. Should I do that? NIH wanted to do testing on my mom, but she declined.
Yeah, that's a good question. The genetics of lung cancer are being studied right now. It definitely sounds like the family has some predisposition, obviously, unless all of them were smokers. So that's the other question is, were they all smokers? Because if they were all smokers, that's a different story. But if they're not mostly non-smokers, there is some hereditary lung cancer. It's not well understood, but there are a few genes that can cause hereditary lung cancer. So I think in a family like that, I would definitely be happy to see them and do a little bit more digging into the story. But anytime you got more than 3 cancers in the same set of the family, you should consider genetic counseling. So any type of cancer. Yeah.
Actually, when you said that during your talk, I was wondering, do they need to be the same 3 cancers, or is it any 3 cancers on one side?
Yep, any 3 cancers on one side, just because those genes, most of the genes cause like a smattering of different cancers. So most people, that is a misconception. They're like, oh, I only have 1 breast cancer in the family, but I've got you know, 12 ovarian, colon, uterine, all these other things. So yeah, it's any 3 cancers, doesn't matter which cancer, just any cancer at 3 people in the family, same side of the family. That would you'd be considered. You may not necessarily need the testing once I do a little bit more homework on your family, but you should at least be referred.
And then speaking of referred, a patient just submitted a question, do I need a referral to see you? And I think I can answer that. It depends on your insurance need, whether you need referrals or not. If you generally, if you have a PPO program, you do not need a referral. But if you have an HMO, you typically do. So that is maybe a question better for your insurance company.
Yeah.
But it would go along with if you need referrals for other specialists too. It's the same vein. So another question, my mom's side has 3 members with breast cancer and ovarian cancer. My mom recovered from breast cancer, had the whole panel genetic testing was negative. Does this patient now need it?
So okay, so that's a good question. So if your mom had a full panel, the question is what panel did they get? But if they had a full panel recently, in modern day, within the last 5 years, and their genetics were negative, then the offspring of that mother would not need genetic testing unless their dad's side has a bunch of stuff. So the genes don't skip a generation. The cancers can skip a generation, but the genes get passed down generation to generation. So if your mom is negative, you are safe. You can't get anything from your mom. Again, if your dad has a bunch of stuff, that's a whole separate story. But if mom was tested, mom is negative, you do not need testing because your mom was already tested. Assuming that testing was current, accurate, and the right genes that were tested. So I always tell patients, just get your mom's testing and make sure, because sometimes they got a panel, but it was 3 genes or something. Like they really need 30, 40 gene panels to make sure they had complete testing. That's a good question.
And then we just have one other question so far. So if anyone else has anything else, please submit it. Actually, this is submitted by a physician. If BRCA testing was done 10 years ago, is it that they need a larger panel done, or the BRCA1/2 itself also needs to be redone? I believe you said yes for both, but I just want to.
Yeah. Yes, for both. So it depends for the BRCA. If they had what's called comprehensive BRCA testing, including BART, so I know this is to a physician, but so patients don't have to know all these terminology, but if it includes BART, B-A-R-T, then that BRCA testing is accurate. But if they only had BRCA testing, they definitely need a panel. If you were suspicious enough to test for BRCA, they need a panel. So looking at the report to see if it says the word comprehensive, including BART, that would mean the BRCA is okay. If it doesn't say comprehensive, including BART, then yes, they need to redo their BRCA testing and they need a panel. But regardless, if they just got BRCA 1 and 2, they're going to need a panel. So we just do the whole thing over again and, repeat BRCA 1 and 2. It's all the same price. This is $250 for all the genes.
All right. And then where do lymphomas fall within this array of genetic deficiencies, and how about non-Hodgkin's lymphoma?
Yeah, so lymphoma and lung are 2 areas that are we're still studying those areas. So there are some hematologic malignancies, including leukemias. That's the one that's kind of more genetically linked, leukemias. But some lymphomas can be genetically linked, but the vast, vast majority of lymphomas are not genetically linked. So most of what we can test for right now is not going to include a lot of hematologic malignancies. There's a couple genes that do get included in those larger panels. But for the most part, it's not well understood. And for the most part, even less than 10% of hematologic malignancies seem to be genetic. So yeah, for the 10% statistic, that's for solid tumors like breast, prostate, ovarian, colon, those kind of things. And then the hematologic, it's a little less well understood. But being studied, so more to come. And again, I tell patients who've had genetic testing, even with me now, I'm like, you know what, check back with me in 5 years. Just make an appointment with me in 5 years, even if you're completely negative, if you have a really strong family history, because there's so much research and so many guidelines that are changing day to day in genetics that you may need update testing in 5 or 10 years. And anybody, and I didn't say this in my talk, anybody who is positive for a mutation, we see them back yearly to give them those updates on the guidelines and to make sure that they're in line with all of their screening protocols. And we have a little calendar for them to follow. So we would see anybody back that has a positive mutation once a year. And then anybody with a really strong family history or someone that I put on a high risk protocol, like they were genetically tested, but we put them through that statistical model and still found them to be high risk. I see them back at least once a year as well to redo the statistical model and make sure they're on track for their screening and give them updates about new genes that may have been discovered.
Okay. Follow-up question from a physician. If a patient's aunt has BRCA2, but the patient's father was negative, does the patient need testing, assuming no other family history?
So I assume it's the paternal aunt that had, yeah. So if it's a paternal aunt that's positive, but the patient's dad was tested, then no, the patient doesn't need testing because it just comes directly from the parents.
Okay.
Yeah.
This is almost like, these are like SAT questions. Like train leaves the station at noon in one country. It's like, you have to like wrap your head around it. Okay.
Yeah, that's very common in genetics.
Yeah. So here it is. Here's another one. My father, mother, and grandmother, they don't say whether it's maternal or paternal grandmother, all died of colon cancer. I have had 16 colonoscopies. Wow. Should I or my 3 children, all above age 50, or 3 grandchildren in their 20s, do testing? Husband has no one in his family with colon cancer.
Well, so the issue is you said it was mom, dad, and grandmother. So yeah, we don't know if it's which grandmother. And then the mom and the dad are not blood relatives. So that really only counts as 2 family members on the same side as having colon cancer, right? Because the dad is on one side, the mom is on the other side, and maybe it's the mom's mom that has colon cancer. The fact that you do have 2 parents with colon cancer, though, but assuming no other history besides that one grandmother, it's a little bit trickier. And then I guess I would also want to know how many polyps were detected on the colonoscopies, because I didn't even get to talk about that today. But if you have more than 12 polyps in your lifetime, that is actually a consideration for genetic testing. So even if you have no family history of cancer, but you have more than 12 polyps on any, not at one time, but like, let's say this person had 12 colonoscopies and they have a polyp each time, that's 12 polyps in their lifetime, they could qualify for genetic testing. So 12 is the magic number for polyps. Anything more than 12 polyps needs genetic testing or counseling. That family history is a little complicated because it's mom and dad, and then I don't know which grandmother. So that might be worth a deeper dive on that family history, and also just how many colon polyps they've had. So maybe that's a maybe.
But in that case, the patient who wrote in would need to be tested. Her children
first. Exactly. You're right. You always start with, you don't just test like 30 people in the family. You start with kind of the person that had the cancer, if possible, if they're still alive. If that person doesn't want to do testing, you can do it yourself, or, whatever, pick a person to get tested. If that person is negative, their children don't need testing. Because you can't, again, the cancer could skip generations, but the gene doesn't skip. So if your mom is negative, you're negative, unless your dad's got a bunch of side, or, vice versa. Your dad's negative, you're negative, unless your mom's got a bunch of side stuff.
Yeah. Is there a higher incidence of breast cancer in individuals of Eastern European descent other than just Ashkenazi Jews?
It's mainly the Ashkenazi. I mean, there's some Slavic populations, and yes, but in general, it's really just the Ashkenazi patients that are at higher risk, and they have a couple genes besides BRCA1 and 2 that actually run in that population, just because that's kind of a population that tends to stay, marry within the other Ashkenazi population. So those genes have kind of been filtered down and have persisted, whereas a lot of other populations are more dilute. So then you don't find those genes as often because they might have mixed races. So the Ashkenazi population, that's why any Ashkenazi with any family history of cancer needs to consider genetic testing, because there's a couple genetic syndromes that run in that population of patients.
All right, and here's our last question before we have to wrap up, but all on the same side of the family. This patient has a cousin with prostate cancer, a grandmother maybe with breast cancer, and a diabetic deceased father who took insulin pills in the 70s, all Ashkenazi. Is a test recommended?
Well, if they're Ashkenazi and they've got any cancer in the family, then I would say at least counseling. So I guess it's important to, you may not qualify for testing, but at least meet with someone like myself or my nurse practitioner. Will look really closely at the family and let you know kind of what the probability of having a gene is and whether you're appropriate for testing. But yeah, any Ashkenazi with any family history of cancer, I would say needs to see a genetic specialist.
All right. Well, let me just make a quick plug for Friday's lecture is on implicit bias. So we're going to talk a little bit about, these are your subconscious biases that are in you. And there was a link sent out for you to do a home implicit bias test beforehand to get a sense of what kind of bias you have. This is for race, gender, weight, all kinds of things. So it should be an interesting conversation between our clinical psychologist, Dr. Moskowitz, and one of our internists, Dr. Carrier Holmes. So please tune in on Friday. That should be good. And then next week, we'll be sending an email out. Sorry, somebody had said they didn't get the test. So it was included in the link with you should have gotten an email for this week, like the way you found this lecture. And then in there was included in that at the bottom of the description of Friday's lecture, there should be a link to the Harvard test. And then I'll double check that it also gets posted to our website, so you can look there. But I just wanted to, quickly, next week, we're going to have a talk on medical marijuana, but we're still hammering out lectures for next week. So stay tuned. But thank you so much to Dr. O'Connor for coming today. I'm glad that she started out with her description of the trapeze classes she takes, so that we didn't run out of time at the end. But if you guys are interested in learning more about genetic testing or concerned about your family history or have any other questions, feel free to make an appointment with her, Shannon O'Connor. If you didn't get a chance to copy this information down, if you Google her, you can find her easily. And that was a great talk. So thank you so much for your time and coming out today. I definitely learned something. I'm sure everybody here learned something today. But yeah, last minute comments before we sign off.
Thank you so much. It was great to be here. Really enjoyable. I love to share genetic information. I wish I could give more talks. I have lots of genetic talks that I would love to give in the future, maybe. So thank you so much for having me.
Yeah, thank you. All right. And thanks everyone. Have a good Wednesday. We'll see you back on Friday. Take care.
Dr. O'Connor, your
Yes.
host, you're going to have to exit out to end the meeting.
I'm trying to, and I keep hitting leave event and it's saying I can't leave. Okay, here we go. Got it.
Okay.